Welcome to Track 10. We now transition into an engaging segment, navigating leadership challenges beyond numbers, rebuilding stability through strategic workforce planning. This section exemplifies the Nurse Leadership Challenge, a dynamic forum where participants address real-world dilemmas with strategic insight and practical solutions. It's a powerful display of the critical thinking, collaboration, and leadership strength that nurses consistently demonstrate in complex healthcare environment. Among 11 exceptional teams, all celebrated for their courage in presenting before our esteemed and a very tough jury, 3 have emerged as finalists and will present their innovative solutions to the challenges ahead. This unique competition, launched this year, is designed to both challenge and honor top-level nursing leaders. What an outstanding start of this year. We extend our heartfelt appreciation to our preliminary jury for their invaluable guidance. Now please join me in inviting our jury to stage for today's presentation with a resounding sound of applause. Dr. Jyoti Clara Michael, founder, HealthBridge. Mr. M.V. Krishnan, Group CEO, Kinder Hospitals. Captain Tangam, Group CNO, Aster DM Healthcare. Welcome. I now invite our first presenter for today, LC 101, on stage. Invite Tripti Nanda and team. You have 8 minutes for your presentation.
Ma'am, we are here from Lifecare Hospitals, and right now at Lifecare Hospitals we are going through a very tough phase. Our hospital is a 200-bedded hospital and we have adequate 350 nurses, but the turnaround is not as much as we would expect. So we are currently facing issues which outline what exactly is our problem, and the team has actually done a need gap analysis. So we will go through this, and at the end of it, we will be able to present to you, sir, that these are our strategies to overcome the issues we have.
So workforce review and feedback data has been surveyed for a period of 6 months, and graph 1 talks about nurses attrition rate, which is at an average of 9%, remains constantly on every month. Moving to the graph 2, it's about new graduates. 40% of the new graduates were at workforce, as well as the in-charges who were of 2 years of experience in almost 65% of the units. Coming to the graph 3 is about doctors' complaints is kept on increasing. Moving to the graph 4 is about patient network promoter score. A deep decline from 55 to 31 due to lower trust in care as well as professionalism. And the final graph is talking about internal training attendance. So there is a deep decline in the training attendance. Only 50% of the staff have attended, and this results in poor quality care, safety, and poor leadership as well as guidance.
Under system-wide safety gaps, we identified 3 types of Manchester gaps. First, attrition analysis, under which we saw abrupt opportunities, higher studies, personal issues, and absconding. Second, training. Gaps were lack of mentorship, lack of hand-holding, lack of individual programs, lack of specialization courses, PLS, ECLS, etc. And the third was staff engagement. Lacks identified were increasing patient complaints, decreasing employee satisfaction survey, lack of collaboration, and lack of professional relationships.
After analyzing system-wide safety gaps, we came up with multi-phase strategic plan. We have divided into short-term goals and long-term goals. Under short-term goals, we want to do 5 immediate initiation. 1. Use of nurse-patient ratio. 2. Use of patient ability tool. 3. Develop competency skill matrix. 4. Initiate robust induction training program. 5. Staff engagement activities. And 5. Initiatives in long-term activities. 1. Leadership development program. 2. Organizational behavior. 3. Ranking system linked with performance appraisal. 4. Formation of quality and patient safety committees. 5. Audits and accreditation.
Under short-term goals, we are looking at the first one, which is nursing manpower. And this is typically a snapshot of what we have developed for our hospital at Lifecare. We have divided all the units, and for 200 beds, we have put the nursing manpower ratios, which are the usual INC norms, as well as taking patient acuity into consideration. This is what our manpower would look like, and we actually have adequate 350 nurses to fill these areas. Looking at the second one, which is patient acuity based, on the left we see patient illness score, on the right we have the nurses competency score. So based on the patient acuity, this immediate short-term goal will definitely look at initiating PAP at all units. The third would be to make a competency assessment. This is, for example, what we have developed for Lifecare hospitals for our own critical care unit, and we will look at various competencies of the nurses in each area. And yes, we definitely immediately require induction training structure. Like my colleague just said, only 50% of our nurses are actually attending even training classes. So we will have to ensure that all 100% of our nurses are attending at least a minimum of 5 hours per bed training class every month, making sure from the date of joining HR induction, preceptor training, preceptive training, evaluation test, and then we've kept a passing score of 60% to start with in the short-term goals. And as an example of our training topics, which is basic foundational for every nurse, is what we have put down here. Finally, not to forget, we must have staff engagement activities because we realize our attrition has been constantly at 9%. We will have to constantly engage with our staff nurses with the mid-level managers. Also, we must make sure that their rewards and recognition programs are intact. Town halls, meeting nurses, chat-in chambers with the CNO, coffee breaks, all of this must be encouraged. And of course, a nurse satisfaction survey at the end of 3 months will tell us if we are doing it right or if we still need to change something. Moving to the LTG's long-term goals, the first plan would be leadership development plan, where a nurse is able to discover, design, deliver and develop herself or himself, and this will definitely start if the hierarchy is defined for a particular nurse. She needs to know her career pathway, she or he needs to know where he fits into the particular nursing system. The second would be organizational behavior. We need to develop a wonderful organizational culture where we will have to emphasize on magnet nursing, where the nurse will feel magnetized to work with the CNO, with the hospital and with our Lifecare hospitals. We will also look at ranking system which is linked with their performance appraisal, because this will help the in-charges or the middle-level managers be more accountable to what they are doing. So if they don't have a medication error, they don't have an indenting error, they don't have an administration error, then definitely that will be linked to their performance appraisal and they'll feel, yes, I've done something really nice and my floor or my unit is bagging the award. So we can make it as a conservative ranking, essay ranking, critical incidence ranking, whichever way we want, we can actually do it. And fourth will be formation of quality and patient safety committees. The 4 outside circles are the cultures we want to do away with. We do not want blame culture. We do not want a hierarchical traditional culture. We do not want a fear culture. Neither do we want a paternalistic culture. But what we want is patient safety and quality ecosystem, which will be the focus and the fulcrum of Lifecare hospitals, where we will be able to speak up, report, be safe, system-wide culture, learning culture, quality improvement, patient-centric, patient awareness, just culture, and finally a resilient culture. The fifth one would be for our hospitals at Lifecare, after a period of 6 months, we will know where we stand, so we will be very, very happy. We will progress to the level of wanting a JCI accreditation or an NABH accreditation. Make sure that Lifecare hospitals has actually crossed all of these hurdles and we come back to do a huge staff employee satisfaction survey. The first, what we actually did, making sure consultant complaints have reduced, making sure nurses are satisfied, making sure patients are satisfied, and our NPS ranking will also increase. Thank you very much.
Thank you, team. Now I invite the second presenter, LC104, on stage. So one question. Okay, it
thought and very creative and very realistic actually, and a pragmatic approach you have given. Just wanted a clarification. One is like, what is the evidence-based route that you have incorporated into it?
Yes.
And the second question is the specific KPIs most relevant to this particular project.
Ma'am, the KPIs are, as you know, it was part of it. The first one, evidence-based practice here, we will look at competency assessment as our evidence. Because if we start with competency assessment, I will tell out of 350 nurses how many fall into competency 5, 4, 3, 2, 1. So that will be my evidence to build on what sort of nursing I will require in my system. Two, the basic KPIs have been part of the ranking system where the key performance indicators basically.
Specifically for the feedback loop.
Feedback, yes. We will take feedback from patients, consultants and from co-workers. So it can be a 360 feedback.
Thank you.
Yes. Ma'am, absenteeism, we will have to collaborate with HR to figure out we are able to reach letters to them or to talk to them. Initially, when they come into our system, I think the hand-holding will help us in reducing absenteeism. It has to be more of face-to-face interactions because sometimes the top management is not really seen with the frontline workers. So if we can do it, I think we'll be able to tackle that, number one. Number two, if they are absent, we can reach out to their friends and from the colleges they have come to us. You know, we can also track them from background. Yes. 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 Ma'am, to increase the NPS score, we will look at a discharge feedback link where the patient can talk to us directly. Also a consultant connect. So for our hospital, we have kept our consultant connect as 3 consultants every month. We would like to have a face-to-face interaction with our consultants, figure out where we lack and what we need to still further do to improve our services for the consultants as well as for our patients.
Quickly one question. I think you've well done a nice presentation. In a very short span of time, coming up with a very comprehensive presentation is really appreciable. Being a CEO, of course, our thought process always comes from the cost efficiency part. Tell me your solution, how cost efficient it is, and also from a scalability point of view.
Sir, it is a very, very cost-effective short-term goals because we literally investing nothing. We are just going to make sure our nurse educators and the CNO is really strong with administrative and educational capabilities. Second will be people process skills. So we have already made processes for life care hospitals. Now we will have to take it with people skills because we cannot follow very democratic styles, autocratic styles. We will have to really do servant leadership where we are part of the team, teaching them, mentoring them and promoting them. Scalability is really huge. Now we can really scale it starting from one unit and then scaling it to the entire hospital. Thank you, sir.
Thank you, team. Thank you, jury. Now I invite the second presenter for the LC 104 on stage.
Good afternoon, dear senior team from the management side. You are having enough number of nurses, but what exactly is the problem? That was a major challenge or the question that we were facing each day. Actually, we are dig detailed into that to know what exactly is the cause, and we identified that it is the nursing attrition which is actually causing the problems. India being a developed country, definitely we will not be able to hold the seniors who are migrating to the Western countries. But definitely we will be able to hold or sustain the existing staff into a number of measures that we will be discussing. So with this, we have gone detailed into the itself to examine the impact of the nursing attrition on patient safety and to identify the strategies to mitigate associated risk in healthcare settings and to improve the patient satisfaction. Major challenges identified were high attrition and workforce challenge, then the weak leadership pipeline, which is inadequate due to inadequate mentoring, the clinical skill imbalance, which is actually impacting the patient care, staff morale and the career stagnation, and definitely the management's perception gap about sufficient staff.
Yes, we identified the problem. What is the exact reason for the problem? We have done a detailed root cause analysis where you can see why the staff attrition has happened. For which we have done a detailed study on this, and we identified the root cause analysis were into mainly 3 buckets. One was staff related, management related, and process related. Here in the staff related, you can see the work related stress and burnout, dissatisfaction with the work-life balance, better career opportunities as the Western countries are giving more benefits to them in terms of salary and benefits, role confusions and ambiguity, conflicts and poor communication among colleagues, inadequate use of available resources, lack of interdepartmental support. Then coming to the management related RCA, we identified that there is unhealthy working environment and culture, doing non-nursing related work. The nurses are doing other department works as well. Poor compensation, no open door policy, inadequate supply of resources, inadequate communication and feedback, professional development opportunities, and there is no rewards and recognition from the HR point of view. Then we understood that there is a lack of process related problems as well. It includes mentoring and handholding, insufficient training and orientation, including the technology integration, lack of streamlined documentation, follow-up and evaluation, insufficient workflow, continuous quality improvement, and there was limited flexibility and scheduling of works. As you know, the mothers are working, the fathers are working, their childs are having problems. So these are the main root cause analysis we identified. Then we have done a survey in the background. What is the exact problem? What is the percentage? We cannot measure until we do a survey. So we understood that the nursing attrition rate was only 9% and total attrition in 6 months were 54% and new graduates in workforce were 14% and the in-charges with less than 3 years of experience were 65 units and the doctor's complaints were 38 numbers. The patient promoter score increased to 31 and internal training attendance were only 47%.
Crisis due to shortage of skilled nurses are day-to-day challenges of our nursing leaders across India, that we all know that. So we have seen the reasons why is it. So to me, we can't stop attrition of our experienced nurses because of the opportunities. They have ample opportunities outside. But however, we can definitely have a control on our freshers leaving our country. At least for 2 years they will stay back with us. So we have decided our action plans to be short-term and long-term. We have already laid down the responsibilities of each of you sitting there. But still, we will just focus it on short-term and long-term. Short-term is in the 6 months. It is an emergency, it is a crisis. So we have decided to keep the communication line open among our staff, one-to-one communication plus open town halls with the representative of the management people like CEO or somebody HR and someone, so that they also can understand what are the challenges they go through. Then next is our staffing program because of the skill issues. We have 14% of the freshers, fresh graduates in our system. When the HR sees, we have numbers, but when we match the competency, it doesn't match anywhere. So we have decided to do a skill mapping and identify the gap and reallocate the staff according to the acuity assessment and the critical areas where they are working, so that there can be a skill mix in a better way. And also there is an immediate crisis of shortage. So we thought of making a pool of staff, floating staff, to manage the workload of the existing nurses. Also freshers, like we have 40% of freshers, and we need to increase this robust preceptorship program to mentor them. So the existing preceptor needs to be trained through a preceptorship program, and we can have a monthly meeting with preceptor and preceptee and feedback based on that for better adaptations. That will hold the freshers in our place. And very importantly, I think that we need to look staff. So we thought of restructuring the salary part of our existing and experienced and expert staff. So in a phased manner, so that it doesn't affect the management in a very drastic way. So we can categorize the staff like OT, ICUs, and we can, in phase to phase, we can give them better remuneration as per the experiences, competencies, and the workload that they are having. And also, leaders, we have just 2 to 3 years of experience, so we need to handhold them too. So we can have leadership training program for them, like train the trainer program, and also some welfare activities for the staff, like refreshment, free tea and snacks and things like that. Mental wellness program for the counseling of the staff who are stressed out, and some vacation and leave, adequate leaves and vacations for them to have a balanced family life and things like that. Also, we were thinking of having flexible shift programs. So we can have some self-scheduling tool so that they can have flexible shift, like mothers who are working, how can they manage their shift without compromising the duty and the job that they are doing. So, and restructuring of like the onboarding program in the right way for the freshers. We have introduced a 6 months onboarding program for the novice nurse bridging program. With that, and week-on-week assessment of them. And in the long term, of course, we need to have a career growth ladder with competitive compensations and benefits. Then only they will stay with us. And technology integration, we can have artificial intelligence prepared care plans and remote monitoring of some activities like vital signs. So that will take up some work from the nurses. And even support staff to take up the non-function of the nursing activities like billing, inventory, maintenance. So we can have the non-nurses support staff for managing them. And of course, empowering the nurses in the boardroom. Nurses and the nursing leaders, including the policy making and decision making. So that will definitely help the nursing workforce to be motivated. So they feel empowered and can be motivated. These are few strategies that we will implement time-based.
So until you monitor, you can't sustain it in your system. So these are the measures we are going to monitor, that is staff attrition rate, feedback analysis, staff as well as patient satisfaction survey, nursing quality indicators, staff attendance, absenteeism and their grievances. And for sustainability, we can conduct onboarding and mentorship program, regular monitoring and guidance to the new employees, open door policy for staff, and strengthening the training by arranging TOT program for leaders and staff welfare activities. So tracking the result of an improvement and putting system in place to make sure that success lasts throughout. Thank you.
Yeah, good presentation again. The difference was there was a lot of energy and there was a lot of clarity when you presented the whole process. So one question from our side would be, how you will be preventing preventable attrition in the nurses.
Just say any strategies you have considered to prevent a preventable attrition, which is within your purview.
Communication by doctors, so we can have one-to-one interaction with them while they are living, and maybe because of their shift pattern they are not able to, or the remuneration. So that is what we look into the competency and the workload they are doing, and we can have some kind of better salary pattern for the people who will stay with us for us, considering their experience and criticality and workload they are having. And the career guidance, career pathways, ladder. So there is stagnation is there in our system. So we can have ladders, drafted ladders, and matching their competency, and with each ladder should have competitive compensation also. Not that simply giving promotions, supervisors and managers, but it should match their positions and the job they are doing. So remuneration is definitely a matter for those who are staying back, and the clinical instructors we can introduce to handle the...
Thank you.
Very good. I think one thing what you said, self-schedule, that's one thing, is a great thing. I think if we try many preventable attrition, we can stop
Also,
it.
we can have specialized
to nurses and specialty nurses.
Thank you. Thank you.
Thank you, team. Now I invite our third presenter for today, LC106 on stage.
Good afternoon, one and all. Good afternoon, ma'am. Good afternoon, sir. There is a problem, and we understand the problem. And we understand the seriousness of the problem, where the patient safety, patient satisfaction, and the quality is impacted in a large level. And it is true that you are frustrated with the thing, and it is truly frustrated. But here we are with the honest solution, where we can make an impact and we can change what it is. In healthcare, it is always told us, it is quality matters rather than the quantity. Let me take you to the data. Of course, ma'am, you have given us the manpower as per the budget and manpower, but when we see the data, it is just not the numbers. But the numbers, how it is impacting the patient safety. 40% of our staff nurses comes under less than 1 year of experience, and whereas 60% is above 1 year. But when it comes to the leadership, it is only we have 35% who is more than 3 years of experience. When we have 40% of new graduates, how is the mentoring happening? When there is only 35% who is more than 3 years of experience. So it is really a very weak leadership coming onto it. We have lots of doctors complaining. So we did a 5 why root cause analysis, where we understood the final why we can see over there is low moral, career growth, and the burnout. Why it is happening? And because of this, there is attrition of near to 54%, which is also an average of 9% per month. For the past 6 months, we are going through it. So this is where we have actual issues that we came to know. Then it is not only the solutions regarding, but it is not only the root cause. There are other. That is the reason we did a fishbone analysis, where all the aspects have been covering it, where the staff reformation, process redesign, and a very leadership has to be taken into consideration. So here in the fishbone analysis, all the aspects is taken into consideration. Next comes to the very, very important, the Gona period, where we understood the structure. When you understood the structure, there is an implication on the process, and because of the implication, the outcome, that is the attrition, the burnout, the poor moral, and the cost burden is to the hospital. And of course, we are sorry with regards to it. Coming on to this, we have developed various strategies, but very important, we have to ensure that the prioritization has to be done in a very utmost importance. So we use impact versus effort model, where there is a very quick win, high effect and high impact, which will be making a rebuilding of what has gone wrong. That is the reason we'll have many other strategies in terms of quick win as well as major projects faced.
To go on with the strategies that we have planned, so we have divided into short-term and long-term strategies. So coming on to the short-term strategies, we have basically mixed the skill-based in all the duty across the shifts, along with super specialty nursing module, and that we are focusing on innovating, that is staff wellness hurdle that we will be doing, and recruitment strategies where we have to strengthen by 30% each of more than 5 years and 3 years of experience staff should be taken. Along with that, not only taking the exit interview, we are focusing more on the stay interview to identify why the retention is not happening, and we have to focus on that and retain our staff. Along with that, we are going to strengthen our localized nurses, that is a skillathon, that will be our main focus. Going on to further, that is floating pool, we will be having leadership boot camp, especially for our unit in charges where there are only 3 years of experience, and rewards and recognition and internal promotion. This is the long-term strategy, that is our work-life balance and the career progression. This will be tracked from a Gantt chart where all the things will be possibly tracked, how much is the activities happening, and with the innovative strategies we are putting forth, we will need a budget mostly for leadership boot camps, and along with the smart incentive, rest everything we will be doing it internally. Smart incentive, as I would like to just focus on, where we will give gift vouchers, 10 days mandatory leaves for the families. These are just a short.
So now coming to the leadership, we request you that yes, we have the in charges who have less than 3 years of experience. Please don't remove them. They are our strength. It is our issues, our structure issues. We have to give give them the training, and we have to develop the leadership level from that. So we are proposing the leadership training module in front of you. Also that we want to put you in the grade 1 and grade 2 leadership development programs for our in charges. I assure you that they will be a good leader going forward. So also I want you to come down to the floor to encourage our staffs who are doing a good job, and let's celebrate the no complaint day when the patients, there is no complaint from the doctors, no complaint from the staff, from the patients. Also the peer review and the group, whatever the recognition we get it from the peers, please do participate with us to encourage our staff so that they get motivated, not only through us, by the leadership levels like you, all of you are sitting here. So we want jointly to come down to the floor and encourage our staff. The retention would be much better. Mentorship programs, we do it, we are putting little more innovations to do the onboarding, because when we did the few of the survey, we found that onboarding experience of the staff are not good. So to improve that, these mentor-mentee programs will be revolved. Also the CAST protocol, which will be even more strengthened, because that escalation matrix was not happening. We are scared because our 60% of the staffs are, 40% of the staffs are newly graduate staffs. So these are the measurable outcomes and KPI. We would definitely do the end-to-end connections to find out that what you are going wrong. We'll come back to you weekly basis if you are getting stuck, and we want your cooperation to help us to achieve them. Removing the staffs is not the solution. That gives a very bad name in the organizations. So we want to strengthen our existing staff and we want to create the leader from them. Now coming to the staff engagement, we want you to give, I know that from the hospital you feel like the patient should be getting and the staff should be getting a culture of safety, that kind of experience. So we want to build our Lifeline Hospital as a very good hospital of culture of safety. So but periodic survey should be done to ensure that whether we are reaching there. And we are doing this survey anonymous. So far we are doing with the name, so we are not getting the right feedback. I want anonymous survey to be done, and we will be presenting the data. Not only that, we also want to keep on doing the patient satisfaction, but I am putting it frame over here, patient-related experience measures, reported experience measures, to understand that what they are feeling about our staffs. So the questionnaire are formed, we are ready to change them as you give us input. And also the doctor survey, we will do it. So all these things, if we put it together, our NPS score will go up. Now coming to the budget, nothing comes without cost. We have staff wellness module, my colleague has spoken about it. We go and ask them about the work. I want HR, being an HR manager, you to come to the floor. Operations, you come to the floor. Talk to them how they are doing. So staff wellness hurdle we want to introduce to understand their health, because they are there at the bedside. And yes, in addition to that, some of the things we want your cost, because the one new nurse, if we hire, and that staffs are going out of this organization, cost per staff is approximately 50,000 rupees. Why not to hire the experienced staffs and give little more money and to attracting them to us, and they will stay for us with the incentive modules. Okay, so these are the budget, but I just want to tell you, sir and madam, you have given us the budget at the end of March, but you have given us something less than 3 lakh rupees for the nursing. This is not acceptable. Today you will learn from this experience what you are going through. Quantity does not matter, quality matters. So approve our budget, strengthen our trainings, give us an atmosphere where we can create leaders out of our own staffs. So yes, budget amount is 82 lakh, don't be scared. We will prove at the end that you are retaining more in terms of the organizational image, patient satisfaction, your occupancy level would even increase more than right now what you have. So yes, this is the sustainability plan. It can be scalable. We can do it for all other departments. So this is the cost and benefit, as I said it to you. We'll come back to you at the end of 3 months, giving the benefit which you are getting. So yes, these are the tangible cost and all that have been put in. As you could see this, we are 4 of us who are standing in front of you, and one of our staff is is going through the maternity leave. She delivered the baby boy. She couldn't come here, but yes, we have gone through a huge lot of exercise putting it in front of you. Your 8 minutes time, but please do sanction our budget. We are in the Lifeline Hospital. Let's Lifeline Hospital get attached to the lifeline of the nurses. So please approve the budget, and we want to do a magic.
Thank you, dear, for the beautiful presentation. I was about to ask something, I was writing, you were answering one by one everything. But only one question, since you said 40% nurses are, very freshers, and your seniors also 2 to 3 years of experience. Like all seniors will go off once the general shift over. What is the strategic plan you have to enroll them in the evening shift and night shift? Your specialty nurses will go up in the morning and your seniors will go up in the morning. Most of the time your freshers will be in the evening and night shift. What is your this thing to support them and enroll them?
Ma'am, what is the competency support that you're going to give for the nurse during
Evening and night shift.
Yes.
Because your 40% nurses
Yes.
only on
Yes.
duty will be.
Ma'am, you probably forgot that we introduced something called mentor-mentee program through that we have a trainer. So every shift we keep the team leader who is experienced more than 5 years. So they are the supervisor as well as the team leader who would be giving them, because we did not have more staffs. So what we did is we shifted from the team leader to the supervisor support, who will be present there one click away. They are available to support the staffs.
So you are changing the full staffing pattern,
Yes.
right? As per the given, it is only 2.5 years in charges are there. So you need to change the staffing pattern.
Yes.
You should have the supervisors and the ward in charges, then team leader and all the shift.
Yes.
Yeah? Thank you.
That was a rocking performance of all three of them. But one final question, I think you permit that. There is something like you said, we. Can you define who's this we? Is it the nursing department or?
No, we don't talk about we are together because we are in the boardroom right now sitting in front of you. Without us, today we have called because you
HR and CEO, you think
Define we.
who is the we, the team of?
everyone, ma'am, everyone, not everyone. Everyone, nursing, doctors, operations,
Okay,
HR.
you have answered. Thank you. Thank you so much. Congratulations to all the presenters. It was fantastic. Thank you, Ms. Tangam. That is a very innovative learning approach. I think this should continue, not only in ANI, in all the organizations and association and every hospital. Thank you so much for the opportunity.
Yeah, I want to thank Annie for this opportunity. I think this exercise, many mid-level hospitals who are going through attrition crisis, there is a lot of learning point, takeaway message. Thank you so much, and thank you all the three team. Really, you all done very well. Thank you.
A big thank you to our jury members and presenters for their time, effort, and valuable contributions to this competition.